Cholelithiasis. Calculi or gallstones usually form in the gallbladder from the solid constituents of bile. They vary greatly in size, shape, and composition. They are uncommon in children and young adults but become increasingly prevalent after 40 years of age. The incidence of cholelithiasis increases thereafter to such an extent that up to 50% of those over the age of 70 and over 50% of those over 80 will develop stones in the bile tract. Pathophysiology. There are two major types of gallstones, those composed predominantly of pigment and those primarily of cholesterol. Pigment stones probably form when unconjugated pigments in the bile precipitate to form stones. Cholesterol stones account for most of the remaining cases of gallbladder disease. Cholesterol, a normal constituent of bile, is insoluble in water. Its solubility depends on bile acids and lecithin, that is phospholipids in bile. In gallstone prone patients, there is decreased bile acid synthesis and increased cholesterol synthesis in the liver, resulting in bile supersaturated with cholesterol, which precipitates out of the bile to form stones. The cholesterol saturated bile predisposes to the formation of gallstones and acts as an irritant, producing inflammatory changes in the gallbladder. 4 times more women than men develop cholesterol stones and gallbladder disease. The women are usually older than 40, multiparous, and obese. That four factors are female, 40, fertile, and fatty. The incidence of stone formation rises in users of oral contraceptives, estrogens, and clofibrate. These substances are known to increase biliary cholesterol saturation. The incidence of stone formation increases with age as a result of increased hepatic secretion of cholesterol and decreased bile acid synthesis. In addition, there is an increased risk because of malabsorption of bile salts in patients with gastrointestinal disease or T-tube fistula or in those who have had ileal resection or bypass. The incidence also increases in people with diabetes. Clinical manifestations. Gallstones may be silent, producing no pain and only mild gastrointestinal symptoms. Such stones may be detected incidentally during surgery or evaluation for unrelated problems. The patient with gallbladder disease from gallstone may develop two types of symptoms, those due to disease of the gallbladder itself and those due to obstruction of bile passages by a gallstone. The symptoms may be acute or chronic. Epigastric distress such as fullness, abdominal distension, and vague pain in the right upper quadrant of the abdomen may occur. This distress may follow a meal rich in fried or fatty acids. Pain and biliary colic. If a gallstone obstructs the cystic duct, the gallbladder becomes distended, inflamed, and eventually infected. That is acute cholecystitis. The patient develops a fever and may have a palpable abdominal mass. The patient may have biliary colic with excruciating upper right abdominal pain that radiates to the back or right shoulder, is usually associated with nausea and vomiting, and is noticeable several hours after a heavy meal. The patient moves about restlessly, unable to find a comfortable position. In some patients, the pain is constant rather than colicky. Such a bout of biliary colic is caused by contraction of the gallbladder which cannot release bile because of obstruction by a stone. When distended, the fundus of the gallbladder comes in contact with the abdominal wall in the region of right 9th and 10th costal cartilages. This produces marked tenderness in the right upper quadrant on deep inspiration and prevents full inspiratory excursion. The pain of acute cholecystitis may be so severe that analgesics are required. Morphine is thought to increase spasm of the sphincter of OD and may be avoided in many cases in favor of meperidine. This is controversial because morphine is a preferred analgesic agent for management of acute pain and meperidine has metabolites toxic to the CNS. If the gallstone is dislodged and no longer obstructs the cystic duct, the gallbladder drains and inflammatory process subsides after a relatively short time. If the gallstone continues to obstruct the duct, abscess, necrosis, and perforation with generalized peritonitis may result. Jaundice. Jaundice occurs in few patients with gallbladder disease and usually occurs with obstruction of the common bile duct. The bile, which is no longer carried to the duodenum, is absorbed by the blood and gives the skin and mucous membrane a yellow color. This is frequently accompanied by marked itching of the skin, changes in the urine and stool color. The excretion of bile pigments by the kidneys gives the urine very dark color. The feces no longer colored with bile pigments or grayish like putty and usually described as clay colored. Vitamin deficiency. Obstruction of bile flow also interferes with absorption of the fat soluble vitamins A, D, E, and K. Therefore, the patient may exhibit deficiencies. Example, bleeding caused by vitamin K deficiency, which interferes with normal blood clotting of these vitamins if biliary obstruction has been prolonged. So, clinical manifestations include pain and biliary colic, jaundice, changes in the urine and stool color, vitamin deficiency. Assessment and diagnostic findings include abdominal X-ray, ultrasonography, radionuclide imaging or cholecystography, cholecystography, endoscopic retrograde cholangiopancreatography, that is ERCP. Another one is percutaneous transhepatic cholangiography. Abdominal X-ray may be obtained if gallbladder disease is suggested to exclude other causes of symptoms. However, only 15 to 20% of gallstones are calcified sufficiently to be visible on the X-ray studies. Ultrasonography has replaced oral cholecystography as a diagnostic procedure of choice because it's rapid and accurate and can be used in patients with liver dysfunction and jaundice. It does not expose patients to ionizing radiation. The procedure is most accurate if the patient fasts overnight, so the gallbladder is distended. The use of ultrasound is based on reflected sound waves. Ultrasonography can detect calculi in the gallbladder or a dilated common bile duct. It is reported to detect gallstones with 90% accuracy. This radionuclide imaging or cholecystography, endoscopic retrograde cholangiopancreatography (ERCP), and percutaneous transhepatic cholangiography we already read in the shorts. Please go through that. And medical management is the major objectives of medical therapy are to reduce the incidence of acute episodes of gallbladder pain and cholecystitis by supportive and dietary management, and if possible to remove the causes of cholecystitis by pharmacologic therapy, endoscopic procedures and surgical intervention. Although non-surgical approaches have the advantage of eliminating risks associated with surgery, they are associated with persistent symptoms or recurrent stone formation. Most of the non-surgical approaches, including lithotripsy and dissolution of gallstones, provide only temporary solutions to the problems associated with gallstones. Nutritional and supportive therapy. Approximately 80% of patients with acute gallbladder inflammation achieve remission with rest, intravenous fluids, nasogastric suction, analgesia, and antibiotic agents. Unless the patient condition deteriorates, surgical intervention is delayed until the acute symptoms subside and a complete evaluation can be carried out. The diet immediately after an episode is usually limited to low-fat liquids. The patient can stir powdered supplements high in protein and carbohydrate into skim milk, cooked fruits, rice or tapioca, lean meats, mashed potatoes, non-gas forming vegetables, bread, coffee or tea may be added as tolerated. The patient should avoid eggs, cream, pork, fried foods, cheese and rich dressings, gas forming vegetables and alcohol. It is important to remind the patient that fatty foods may bring on an episode. Dietary management may be the major mode of therapy in patients who have had only dietary intolerance to fatty foods and vague gastrointestinal symptoms. Pharmacologic therapy: ursodeoxycholic acid UDCA and quinodeoxycholic acid, that is quinoidal CDCA. Pharmacologic therapy and non-surgical removal of gallstones. Under this, dissolving gallstones, stone removal by instrumentation, extracorporeal shockwave lithotripsy, intracorporeal lithotripsy. Already we read in the shorts. Please go through that. Surgical management. Surgical treatment of gallbladder disease and gallstones is carried out to relieve persistent symptoms, to remove the cause of biliary colic and to treat acute cholecystitis. Surgery may be delayed until the patient's symptoms have subsided or may be performed as an emergency procedure if the patient's condition necessitates it. So under this, laparoscopic cholecystectomy, mini cholecystectomy, choledochostomy, surgical cholecystostomy and percutaneous cholecystostomy. These are all the procedures done under surgical treatment. These topics already we read in the shorts. Please go through that. Thank you.